Now, let me finish this section of upper GI disorders with some talk about the very frequent complaint of nausea and vomitings. And we're going to discuss some antiemetics. Before that, let's discuss the pathophysiology of nausea and vomiting. Why do we vomit? Why do we vomit? What initiates the vomiting reflex? In order to actually do the act of vomiting, the vomiting center in your cerebral cortex has to be stimulated. And this vomiting center will receive impulses coming from the vomiting center in the medulla. And when the vomiting center in the medulla has received enough impulses, enough information to stimulate it, it's going to project to the cerebral cortex, and this is where the muscular movements, the muscular signals for the act of vomiting will be initiated. So the big question is, what are the sources of information? What are the sources of data? What are the sources of stimuli that might take the vomiting center to this threshold? Well, the vomiting center receives, of course, information coming from the GI. You have some unwanted gas in the GI. You have some pathogens. You ate something that was not so good. You have bugs. You had bugs in your food. And these bugs were irritating your GI. And the GI will be screaming and sending impulses to the vomiting center. We have some unwanted gas here. We want to get rid of them. And this will will keep the threshold, or will reach to the threshold, and this will stimulate the vomiting center. Another source of information might come from your inner ear. You have some vertigo, and the inner ear that controls your equilibrium, when it is disturbed, it's going to send impulses again to the vomiting center, the medulla. Even impulses can come to the vomiting center from the higher cerebral cortex center. You might see a bad scene, an accident or something, and this will really disturb you, and your cerebral cortex will send impulses to the vomiting center. This is nauseating, this is disgusting, and you're gonna be kind of having this tendency to throw up. And finally, a very important source of stimulation to the vomiting center is what we call the chemoreceptor trigger zone. The chemoreceptor trigger zone is located deep in the brain in the fourth ventricle, and it can be stimulated by various stimuli. And once you stimulated the chemoreceptor trigger zone, it's going to send impulses to stimulate the vomiting center. So let me review. The sources of information stimulating the vomiting center are chemoreceptor trigger zone and the neurotransmitters. All these receptors utilize chemicals to communicate information, and the neurotransmitters utilized by the CTZ are acetylcholine, dopamine, serotonin or 5-HT, histamine, and neurokinin. Also, stimuli coming from the GI tract will go to the medullary center, vomiting center, and stimulate it, and the GI signals will utilize serotonin, dopamine, and prostaglandin. Stimuli coming from the labyrinth, the inner ear, will stimulate the medullary vomiting center, and the inner ear utilizes mainly acetylcholine to send signals to the vomiting center, and also utilizes dopamine and serotonin. And finally, stimuli coming from the cerebral cortex. All these will stimulate the vomiting center in the medulla, and then the vomiting center will project to the motor cortex to initiate vomiting. Let me review more the sources of stimulation to the CTZ, or chemoreceptor trigger zone. As you can see in this diagram, we have 5 different receptors. We have serotonin receptors, and if you block these serotonin receptors with a drug like ondansetron, you are going to do a lot in blocking this source of information, or this source of stimuli going to the vomiting center. That's why ondansetron, the serotonin blocker, is one of the very good, very potent antiemetics. Also, the histamine 1 receptors are stimulated by histamine, and this will stimulate the CTZ, and the CTZ will stimulate the vomiting center. That's why we can use diphenhydramine, Benadryl, or meclizine, antivert, especially when you have this nausea coming due to motion sickness. For treating motion sickness, meclizine. What's the meclizine? It's an histamine blocker, H1 blocker. Also, acetylcholine, muscarinic receptors. Acetylcholine, via stimulating the muscarinic receptors, will stimulate the CTZ to stimulate the vomiting center. So scopolamine, transderm scop. Transderm scop could be antiemetic also. Dopamine receptors, D2 receptors, will respond to dopamine, and this will stimulate the CTZ. And that's why promethazine, Phenergan, metoclopramide, Reglan, have antiemetic effects because they block the dopamine receptors in the chemoreceptor trigger zone. And finally, we have lately discovered a new kind of neurotransmitter and a new kind of receptor in the CTZ, neurokinin 1, and the aprepitant in new antiemetic medication, MN, is now used as an adjuvant to ondansetron in chemotherapy-induced nausea and vomiting. This table includes the most commonly used antiemetics by far. The two important indications for antiemetics are post-surgical, in post-surgical patient, a patient who underwent surgery. Post-operative nausea and vomiting is a very known entity of complications for surgery, and also chemotherapy-induced nausea and vomiting. And the third indication is going to be motion sickness. For post-operative nausea and vomiting and chemotherapy-induced nausea and vomiting, the drug of choice is going to be ondansetron. How does it act? It acts by being a serotonin antagonist. Anticholinergics can be used for motion sickness because anticholinergics have also some effect because the acetylcholine comes from the labyrinth and irritates the vomiting center. But more importantly, for motion sickness is going to be the antihistamines, H1 blockers, diphenhydramine, Benadryl, and meclizine anti-VERT. Metoclopramide, as I said, can be used. Metoclopramide can be used for nausea and vomiting because it's a dopamine blocker, and also metoclopramide increases the gastric motility and helps keeping the stomach empty all the time. And of course, when your stomach is empty, there is going to be less probability for you to feel nauseated. And don't forget the neurokinin antagonist aprepitant. It's used as an adjuvant to ondansetron for managing the chemotherapy-induced nausea and vomiting. For our case study, this patient actually is a post-surgical patient, an 83-year-old male who is a 5-day post-status surgical patient for elective repair of abdominal aortic aneurysm, and he presents with nausea, vomiting, bloating, and abdominal distension. Actually, this is, as I said, one of the two big entities of causes of nausea and vomiting, post-surgical or chemotherapy-induced nausea and vomiting. I'm not going to go through the details of the surgical causes of nausea and vomiting or the post-surgical causes of nausea and vomiting. I'm just going to focus on the management of nausea and vomiting in general. So the two major contributing factors to this patient's nausea and vomiting are most probably acute, what we call acute colonic pseudo-obstruction secondary to surgery, which is a known complication after abdominal surgeries, and the use of morphine for post-operative pain. Morphine is very important for post-operative pain, but one of the side effects of morphine is nausea and vomiting. Question 9, the pathophysiologic mechanism that underlies acute colonic pseudo-obstruction. As I said, I'm not going to go deep through that, but an increase in intestinal sympathetic system activity or decrease in sacral parasympathetic activity, or both, is believed to impair the motility of the colon. Now, surgery and anesthesia are very stressful events. When you are under stress, how do we fight stress? When you are in a threatening condition, what is the portion, the division of the autonomic nervous system that is concerned with fight and flight? It is your sympathetic nervous system. Under surgery and anesthesia, your sympathetic nervous system is taking the upper hand. Your sympathetic nervous system is inhibiting your gut, because this is the effect of the sympathetic nervous system, to inhibit the gut, to inhibit the motility of your gut, and your parasympathetic nervous system is no longer working, so you get out of surgery with a very dominant sympathetic tone in your gut, and this will hinder the motility, and this will result in the condition of acute colonic pseudo-obstruction. Question 5, and this is the most important question actually in this case study. We are always concerned when it comes to vomiting in these two special populations, elderly and infants. Elderly and infants. We are always so much concerned about dehydration. So what were the clinical manifestations of dehydration in this patient? All of these manifestations. Dry mouth, dry mucous membrane, slightly lethargic, low blood pressure. And let me add another important sign here. Maybe it was not mentioned in this case study. When you have a patient that is susceptible to be dehydrated or is dehydrated, you want to evaluate the dehydration by evaluating the blood pressure. You need to measure the blood pressure twice, once with the patient lying flat and once with the patient sitting or even standing. Normally, there should be no more than 10 millimeter mercury difference in the systolic blood pressure. When the patient stands, the systolic blood pressure is going to drop a little bit, but by no more than 10 millimeter mercury. If the patient was dehydrated and you measured his blood pressure on standing, you will see very severe drop in his systolic blood pressure, what we call orthostatic hypotension or orthostasis. So orthostatic hypotension is one of the important findings in dehydration. Also low body temperature, and the skin temperature is cool, and the pulse is kind of weak, and all these manifestations of dehydration, very important sign to be evaluated in patients with nausea and vomiting, especially elderly and infants.